Hi, my name is Jensen, and I'm a registered nurse. I'm the Director of Operations for ASPEN Healthcare here in Austin, Texas. I'm happy to talk to you all today. My topic is hospice and palliative care and knowing the difference. But because I know you're all caregivers and I want to help us have a little fun and know that all of us are going to age as if we're lucky, I'm going to start off with a little joke. So there's three sisters living together, and the first sister draws a bath, gets her nice warm water, starts to go to put her leg in, gets about ankle deep, and yells down to the other two sisters, "Was I getting in or was I getting out?" The middle sister says, "Well, let me come up and help you." She starts up the stairway. She gets about halfway up and says, "Well, was I going up or was I coming down?" So the third sister, the youngest, who's 94 years old, says, "My word, I hope I don't ever get old like you two," and knocks on wood. "I'll be up to help you as soon as I answer the door." I didn't make that one up, but I heard it on the radio and it was a good one. So let's talk today about palliative and hospice services. ASPEN Healthcare, the company I work for, provides both. We provide services throughout the Round Rock, Austin, San Marcos, Seguin, and New Braunfels area, and provide both service lines, which a lot of people have a lot of confusion about. As caregivers and as people that are loving and helping and taking care of other people, it's most important that we educate and help the community know about the resources that are out there and take some of the stress and the fear off of how to get the services and whether or not you might be eligible. So let's talk about palliative care. Most agencies providing palliative care are providing this care under the home health benefit. The word palliative can be used in a lot of different ways and usually involves a team of people that are helping reduce the stress of a serious and complicated illness. Here in this part of Texas, we provide this service again under the Medicare benefit. It's 100% covered and taken care of as long as a person qualifies and meets the criteria that are set by Medicare. And the Medicare benefit can help to take care of people in short and specific episodes. A palliative care team would consist of a physician that usually is involved in the referral process and helping to get these services, nurses, social workers, physical therapists or occupational therapists, speech therapists, if that was indicated, and also our CNAs. Kind of the backbone of what we do is help to take care of people and educate people and take the stress off of being a caregiver or a family member of someone with a serious illness. So, something to point out is that oftentimes people undergoing palliative care are continuing to have treatment or seek a cure for their serious illness. When we think of this, we think of illnesses like diabetes or cancer or dementia, where a person might still be pursuing treatment or pursuing activities or services or treatments that might help to reduce um, the problems that these illnesses create in their life and help extend their life and the quality of their life. So, the most important thing for us to know about palliative care is that it's available if a person qualifies for home health and if a person has a serious illness that we're interested in helping to alleviate the symptoms of. Most importantly, we talk about reducing discomfort, reducing pain, reducing anxiety, trouble sleeping, those things that can really affect and impact our life and our everyday activities. But also important to note are how important the activities of taking care of ourselves are. Bathing, eating, paying bills, being a part of your family and friends, and being a part of your community. So palliative care is a great option for people that are looking for the tricks and the tools and the assistance to help them better manage a serious condition, and has an entire team of people that can help us to do that. Some of the other things to think about are that it is paid for by Medicare. It's something that is part of the benefit in a short-term intermittent series. And it involves an RN like myself coming out to your house and helping you to and assessing whether or not the person qualifies and helping to get resources started. That nurse will communicate back with the physician, the doctor that's in charge of your care, and help make suggestions and recommendations, and also carry out that doctor's orders to help you with the assistance of these other people. This is specialized and holistic care for a person with a serious illness that may or may not be looking at their end of life. Oftentimes the hope is to return to a level of function, to get better, to improve in independence. And sometimes the services and the support and the guidance can help completely change the story of a family that doesn't know where to start. So palliative care is a great time to have nurses and skilled caregivers and our social worker help get involved in looking for ways to create systems that will better work for you. The aim is to reduce discomfort, to elongate the quality of your life and health and happiness, and return to independence and or create systems that can help smooth out some of the bumps in the road and the stress on a family that comes with a new diagnosis or a terminal illness. Some other things that go along with palliative care are whether or not a person would continue to work with their doctors. The answer there is absolutely yes. Your primary care physician, your specialist, your oncologist, your rheumatologist, those people will continue to be an active part of your care plan. But usually a palliative care physician, or the person that's leading the show in this instance, would be the person that is helping you to navigate a difficult illness and is helping you to find the resources that work for you to stay at home or wherever you would like to be, and to give some gentle, graceful support and help to the family unit. Here in healthcare, as time goes on, we talk more and more and more about the importance of you guys, the caregivers, the people that are doing the work and the day in and day out support of people with difficult and long-term illnesses. People are living longer. People are more interested and invested than ever in living their very best life. And these systems are in place to help to do that. So having a team of people on your side is never a bad thing. That also provides extra tools in your toolbox as a caregiver, as a wife, as a sister, as a daughter, to help your fatigue and the caregiver burden, and to help you do the very best that you can to support a person while also maintaining your own health. So that's a big focus. And when you hear people talk about palliative care, a lot of people have a hard time even saying it. But what's most important is that this is a kind of a new concept and a new niche in healthcare that in fact has not a lot of statistics and not a lot of funding. There's not a specific benefit that's been assigned by Medicare for palliative care. That's why we're able to utilize the home health benefit, but have a specialty focus and have people that are interested and invested in this specialty to be able to help you navigate difficult situations and difficult choices. So again, we're looking at the full family unit and not just a person that's had a new diagnosis or had a change in their health status. We're looking at supporting the whole family in all the different ways that we might do that. So these people can continue to get therapy, they continue to see their doctors, they continue to be involved in treatment, chemo, pain injections, whatever it might be that is helping them to continue in pursuit of either a cure for a serious illness or helping to elongate their life. So the other part of this, the other piece of this puzzle is actual hospice care. And something that's so important to me and to my team as a whole is educating people and helping people to find the resources and to help us get to hospice faster. In the United States, we have a difficult time helping people use the hospice benefit as it's intended to be used. The statistics are that people enter into hospice care way later than they should or could to maximize the use of these benefits. The hospice benefit was created so that people could live wherever they choose to live. This could be at home. This could be in a nursing home. This could be in the assisted living. Wherever a person chooses to live, they are entitled to the hospice benefit if they meet certain criteria that their illness is life limiting. So that's another really important piece of the puzzle. And we're going to talk in a moment about our top 10 myths and untruths that are out there that help prevent people from feeling comfortable about hospice or getting hospice care. But the important piece is that that life limiting means that you have a diagnosis that could be expected to limit your life and could kill you if the disease took its normal course. And sometimes I use language that can be difficult for people to hear, but I want to make sure that people really understand what that means. My love language and the way I talk to people is full transparency and honesty. So I hope that works for you. So a life-limiting illness is something that if the disease took its normal course, it could be expected to limit your life. And we do look for a certification or an attestation from a physician, from two physicians, and a team of clinicians and professionals that you are within the criteria that you might die within 6 months of the beginning of the episode. So we're going to talk about those myths in a minute and what that means. But let's look at what hospice care brings to a family as a whole. Hospice care under the Medicare benefit, which most of our patients that come to us do come under the Medicare benefit. We do also see quite a group of patients that come to us under Medicaid, which is also a payer for hospice. And we also see some people that use their benefits under commercial plans and managed Medicare plans. All of these plans pay for hospice at 100%. There are no copays, there are no deductibles, and there are no loopholes or workarounds for people to not use their benefit if they qualify. The things that come with hospice care, similar to palliative care, the hospice benefit and the hospice team consists of a doctor, quite usually the medical director that is the head of the hospice and helps take responsibility and wraps their arms around that patient and that team. You'll have a registered nurse case manager that will work with you to provide education, find resources, help monitor the status of the patient. One of our biggest focuses in hospice is also comfort. And when we talk about comfort, we're not just talking about the difference between terrible pain and medium pain. We're talking about the ability to maintain and live the best that you can possibly live. When we get to the 10 myths, one of the big ones has to do with people thinking that they're not going to get their medications, or that they're not going to have their pain managed. They're just going to be drugged out or sedated in some way. And that's not at all the intent. The focus is to reduce the anxiety, reduce nausea, reduce the symptoms that might have come from treatment or from the disease process, and limit those so that you can live and enjoy your friends and family and be a part of your story and engage. That's the whole focus for the hospice benefit, is to help you be involved and help you and your loved ones again navigate a difficult part of your life and change the course of the life, change the whole story of the end of life, not just for the patient, but for their daughters, for their sons, for their family members and their spouses, to help them be able to take care of themselves and each other, but also to be a part of life. We talk about hospice as, is it being for the dying or being for the living? Because, and again, on our team, we talk about why a person would do hospice and whether it does reduce the days in your story. And there's great statistics that say it absolutely doesn't. In fact, on average, a person lives 30 to 60 days longer on hospice care than they do without. So I want everyone for just a moment to stop and think about whatever your beliefs are and whatever your perception is of a person's personal expiration date. Would having services change that date? Would it speed up the day that you were meant to die and the day that your story was meant to be stopped? And statistically and truly, the way that we all know that to happen is that when people have loving, caring, clean, dry, pain-free times where themselves and their family are being cared for in a beautiful way, that they're actually able to live longer and in a more fulfilling way. So we'll talk a little bit more about that when we talk about our myths, but one of the biggest ones and the most unfortunate is that people think that going on hospice care in some way would reduce anything in their life, when actually having a CNA come to bathe you every day, taking that burden off your children and your caregivers and your wife or your husband, it can never be a bad thing. Having a nurse that's managing your medications and helping you to stay pain-free and be able to keep food down, and monitoring and addressing and assisting with your hydration status and your nutrition. Having a social worker that's helping the entire family unit come to terms with your illness and how to honor you and how to respect you and how to help you be in charge. I've never seen that be a bad thing. So the things that are covered in the hospice benefit are skilled nursing, having a nurse case manager that helps to navigate your care for you and your family. That starts in the very beginning. The nurse comes to make an assessment. At the time of that assessment, they're going to coordinate with the physician to get your comfort kit. You'll hear people talk about a comfort kit or an emergency kit. Those are the tried and true medications that have the fewest and smallest degree of side effects that can help us to manage your pain. They've been approved by our physician, and each dose and schedule has been created just for the patient and their complicated list of needs. So the nurse comes in, we start going with a comfort kit, we talk with the doctor, we have a detailed report where we talk about the family and all of the things that would help them. The next phone call goes to our durable medical equipment group. We call that DME. The hospice benefit pays for all equipment that's needed in the home, whether that's a hospital bed, oxygen, a wheelchair, a walker, a shower bench. We look for specialized mattresses to help protect a person's skin or reduce skin breakdown. All of these things are delivered same day by our DME company that works with us. That helps us kick off things with a bang and make sure that a person has everything they need. The next thing is that we provide all of the supplies under the hospice benefit. So that includes incontinence supplies, briefs, creams to help protect the skin, um, uh, undergarments, pads for the bed, pads for the wheelchair, everything that's included in hygiene. So lotions, shampoos, rinse-free body washes, again, detailed to however a person gets their hygiene, whether it's in the shower with our CNA or a bed bath, or whether they're temporarily or for the long term bedbound. But many of our patients shower in their shower with the help and support of our CNA and our team on a shower bench that we've provided in case they become tired or fatigued, with all these great products that we bring. So in addition to all of the equipment and all of the supplies and the incontinence care, the hospice benefit also pays for any medications that are related to your hospice diagnosis or that are related to comfort. Your other medications, again, that's on the list of the big myths. We don't cut out your other medications. The other medications you'll continue to take and they'll continue to bill to your Medicare Part D or to your prescription plan. But the hospice takes responsibility for anything related to comfort, anxiety, sleep, nausea, restlessness, and pain. And anything related to your hospice diagnosis or your reason for service. In addition to reduce the caregiver fatigue and to help the family unit, um, we have all of those medications delivered to the home. And part of what the nurse does at every visit is evaluate if you have enough medicine, if you have enough supplies, if you have everything you need, and to refill those and to take care of those. And our medical director will take care of your refilling your prescriptions, monitoring your medications, and helping to stay on top of the disease process. So we've covered the main pieces, which are that hospice pays Medicare pays 100% for the hospice benefit, that all things involving supplies, hygiene, equipment, and medications are covered under the benefit as a support, and also that you have this team, this holistic and broad team of people to provide medical support, but also emotional support and end-of-life planning and grief and coping preparation for the entire family. We work with volunteers to help support the family. We have our chaplain, our spiritual coordinator, is a phenomenal resource to families that is there for the patient, but also for the caregivers to talk about what a celebration might look like, or to help a person kind of review their life and to think about the things that are important to them. And as a nurse, and as a teammate to the spiritual coordinator and to my social worker and to my CNAs, all of us are focusing on what a person wants and needs, what will bring them joy, what do they need to do before their end of life, what would their family like to see happen. um, and we work together to support that as best we can. So that's kind of what our team looks like and the people that would be involved. Our social worker is involved in lots of paperwork and planning, helping people get their affairs in order, looking for additional resources, helping to find any extra help, turning over rocks and looking for any possible places that we could help reduce the burden. So you guys that are the support and that are taking care of people who, there's no doubt in my mind, have chronic and long-term illnesses. Um, Let palliative care and hospice care be a resource to you, and let us help you to navigate and see if the people you love qualify, and where we might get help. So I want to finish with the top 10 myths, and I'm gonna have to keep them straight with my fingers and toes here. But let's talk about the top 10 myths and downright lies that are out there in the community about hospice care. And I feel like I spend every single day talking about these things with people. So a great place to go if you're ever curious about the home health or hospice benefit is the CMS website, which is the Center for Medicare Services website. They also have a great tool called Hospice Compare that helps people look at satisfaction scores and what people's experience was with a hospice company. Um, I want to personally invite you to read reviews just like you would before buying a car. Look at the reviews on Google, look at reviews on Yelp, look at reviews on Facebook. Where else do we go for our information and knowledge? Um, Start off at Centers for at the CMS website and look into the Medicare services, but also read reviews and look at what families have to say about how these services helped them. And also remember that you can take as little or as much as you'd like of these services. If you don't want the chaplain, if that's going to be a place of stress for you, you say no. If the nurse is coming too often and you're just too busy living your best life, you're the boss, you're in charge. Um, there's lots of ways for you to be in control and help take care of that. So myth number one is that you may not be on hospice services without a DNR, a do not resuscitate order. It's absolutely untrue. I don't know who keeps telling that story. Um, you absolutely can be on hospice services without a DNR. Now, we do encourage people to think about the hospice philosophy and what being resuscitated would mean for an individual and for their family and what that would look like. Um, Most of our patients have made the decision to not go back and forth to the hospital or to not have CPR or to not to be intubated before they come on hospice. Honestly, most of our patients have already made that decision before they come to us. But if that's something that you need more information about, you need to talk more about, our registered nurses and our social worker are here to help you through that and to navigate those decisions with the respect and dignity that the patient deserves. So there's not a rule about that. That's completely made up. Number two, on the top list of things that drive me crazy, is that hospice is expensive and that that people can't afford it. Um, I know that it sounds like a dream come true to have all these amazing skilled clinicians come to your house. But if you qualify and if you have a life limiting illness, this is absolutely paid for 100%, like I said, by Medicare, Medicaid, and most commercial insurances. So being expensive is not something that should ever prevent a person from getting hospice services. Number three on the list of things that are myths perpetuated out there in the community that I want to fight is that hospice is a place. Hospice isn't a place. It's a philosophy of care and it's a service line. It's a group of services that people are entitled to. And it can happen in a variety of places. It can happen in a nursing home. It can happen in your assisted living facility. It can happen in your daughter's back bedroom. It can happen in your studio apartment. There are specific cases where a person will be on hospice for a short amount of time in a hospital or in a facility, usually only when symptoms are unmanaged and to get someone stabilized. So there are many, many hospice companies in town, and all of us are working to fight that perception that there's one hospice or there's one place that you go. The benefit is there for wherever people call home. I'm happy to see you in a treehouse. Okay, number four on our list of things that drive us crazy that are not true is that hospice is only for people with cancer. Again, we go back to the statistics and the facts, and that's that cancer is no longer the leading reason that people are on hospice. We see patients with congestive heart failure. We see lots and lots of patients at the end of their life due to dementias or Alzheimer's, Lewy body dementia. We see people with ALS in the home quite a bit. People with HIV and AIDS living at the end of their life. Um, there's many illnesses, pulmonary fibrosis, COPD, that are life limiting, and that when a person is advanced enough to qualify for services, we step in and they're able to get all of those things. The next on our list is that if you're on hospice, you may not live longer than 6 months. Absolutely untrue. We do certify, again, that terminology that I use to go back and to think about if a disease took its normal course, could you or might you die within 6 months? We have to have a way to rein it in and to make some limits and parameters. But some patients come on hospice services for a very short amount of time, and some people continue on hospice services for a year or 2 years. That's not uncommon. So we kind of look at what the two different ends of the spectrum, and usually the shorter end of the spectrum, we look at what a disservice and how unfortunate it is that people didn't get to have all of their services. So next on our list is that hospice is only for patients that don't need a high level of care. That's just absolutely not true. We have patients that have a variety of needs of care. Some people don't need nearly as much as others. Some people need daily visits and a lot of support and help. And some people say, you know what, I'm things are under control. I'm feeling good and comfortable, and I don't need as much as someone else might need. Another myth is that hospice would require family members to provide care. That's not necessarily true. We look at ways to piece together care and help take care of someone, again, with dignity and grace, until the very end of their days. Hospice is only for people that are bedridden or very ill. I would say at least once a week I call someone because their doctor has recommended hospice and they say, I'm able to walk around, or I use my wheelchair, or I use my walker. I don't need a hospice. I'm not in the bed dying. And that's a myth that we're working to help to combat and fight to get people to see all that there is out there. Hospice means that hospice means nothing else can be done, and that's not necessarily true. It is a philosophy of care that involves whether or not a person is going to be cured. And there is a grace and an ease in hospice and palliative care work that we're able to really admit that none of us are making it out of this alive, you and I included. So, but how long and under what quality and quantity is what we're always working on. And the last but not least, that's really important, is people thinking that once you go hospice, there's no turning back. And coming back to the words that I love to use, the dignity and grace and respect and independence, is that a person and their family are always in charge. You are the boss. And there's nothing contractual, there's no piece of paper that you would sign that say that you'll never change your mind. You can change your mind with a phone call or a text message at any time. If you decide that you want to go back and pursue aggressive treatment, if you want to remove your DNR, if you want to go to the hospital, if you want to try one more time for something curative, that is something that we will help you to navigate and support you to do. There's nothing that needs to be scary or intimidating that says that you can't ever change your mind. You're the boss, you're in charge, and we're there to help support you and your family, the people that you love, and to help make this transition easier for you. So as caregivers and as lovers and as mama bears and papa bears and the people that you are that have asked or requested or signed up for more information as a caregiver, I want to give the hats off respect to you and the appreciation and the moment of beauty and sunshine and grace to you that you deserve for doing all that you can for the people that you love. And that there are services and resources to help you. And that many times people sign up for them when they don't get to feel the true magnitude of those services. So if I can ever help you, please let me know. It's an honor to be involved in these other great people and hear about their information and to know these great people in our community that care about doing the very best work that we all do. And thank you for your time. And if I can ever help you, please reach out to me. Thank you. Bye-bye.